Assalamu alaikum everyone. Welcome to VR Duchess. Today we are going to discuss the final steps of phaco surgery, IOL insertion, and wound hydration. After complete cortical removal and before inserting the IOL, the capsular bag should be adequately filled with viscoelastic. The purpose is to push a posterior capsule backward, deepening the capsular bag and create sufficient space for safe IOL implantation. Sometimes enlargement of the main incision is required, depending on the diameter of the IOL injector. However, there is one important rule. Fill the EC and capsular bag with viscoelastic before enlarging the incision. If you enlarge the incision first and then attempt to inject viscoelastic, the posterior capsule may move forward and become vulnerable to injury, like in these cases. Once the bag is adequately filled, you can proceed with IOL insertion. One useful technique is to use a second instrument, such as a shopper, to gently guide the tip of the IOL injector through the main incision. Once the nozzle is safely inside the anterior chamber, the IOL can be injected smoothly into the capsular bag. After the leading haptic is inside, the trailing haptic needs to be positioned carefully. You can use the shopper to assist with the unfolding of the IOL and to help achieve proper centration inside the bag. This is helpful in the screw injector. You can use your both hands to inject the IOL after stabilizing with the second instrument. Another technique is to use the second instrument to stabilize the IOL injector and maintain good wound coaptation during injection. But remember, stabilization does not mean pushing. Excessive injection force can transmit significant pressure to the capsular bag and posterior capsular rupture. As you can see in this case, aggressive injection force will result in posterior capsular rupture. The IOL can also be injected without a second instrument, provided that there is a good coaptation between the injector nozzle and the main incision. However, if you lose this coaptation during injection, the IOL may fail to enter the AC and can even be delivered outside the eye. Another important point is the force generated during IOL injection. Excessive force can potentially result in posterior capsular rupture or even zonulateritis. Once the IOL is inside the eye, we need to safely place the trailing haptic inside the capsular bag. For this maneuver, think about two small movements with the second instrument. First, a slide downward movement, then a gentle sliding or rotational movement towards the trailing haptic, ideally at the optic haptic junction. The movement should be minimal. If you push excessively downward, you may stress the posterior capsule or the node, resulting in complications such as posterior capsular rupture or back dialysis. The second component is the sliding movement. If you push downward but lose the position of the shopper at the optic haptic junction, the shopper may simply slide over the surface of the IOL rather than engaging the haptic. So don't rely on the force. Precision is more important than strength. As demonstrated here, a very gentle and controlled movement is sufficient to place the haptic safely inside the bag. Another common mistake is applying excessive anteroposterior force to the globe while trying to manipulate the IOL. You can actually see the cornea corrugating and the globe being pushed downward. This is unnecessary and potentially dangerous. Remember the seesaw effect as previously discussed by Professor Dr. Ahmed Tawfiq. Instead of pushing the shopper aggressively downward, slightly elevate your hand externally. This allows the tip of the shopper to move downward smoothly while minimizing the pressure on the globe. Now, let's hydrate the wound. The principle is simple. During stromal hydration, fluid is introduced into the corneal stroma, causing the stromal tissue to swell. This helps the incision to reapproximate and seal itself. The key is to direct the cannula toward the stromal tissue and inject gently without transferring excessive force to the globe. There are two different forces you need to be aware of. The first is external force on the globe. If you push too hard with the cannula instead of transmitting the energy to the stromal tissue, you may simply push the globe backward. You lose your hydration efficiency while simultaneously increasing pressure on the eye. As you can see here, excessive pressure causes movement of the globe during injection. And again here, too much anteroposterior pressure results in compression of the globe and collapsing of AC. So the goal is not to push harder. The goal is to direct the injection precisely in the corneal stroma. The second point is to monitor the descent membrane carefully. Excessive or misplaced hydration can potentially result in descent membrane detachment, so always observe the corneal tissue while hydrating the wound. Another useful technical point is instrument stability. When holding the cannula with your dominant hand, use the other hand to support or stabilize the tip of the cannula. Without adequate control, the cannula can suddenly slip forward during injection and behave like a bullet, penetrating deeper into the corneal stroma or even causing unintended tissue damage. So maintain a stable tip, use gentle pressure, and hydrate the wound gradually. And that's it. The IOL is centered, the viscoelastic is removed, the wound are hydrated, and the case is complete. Thanks for watching.